Good evening, everyone. My name's James Aiken. I'm the chair of the ANZELA management meeting, and I'll be chairing this meeting tonight. We're going to start now. We've had a very large number of people register, and I'm sure more will join during the course of the talk. If I could just do a few housekeeping issues first. We will be, during the presentations, arranging for your microphones to be switched off, and if you could check that as well. At the question time, we will open the microphones, but because of the large number of people, if you've got questions, I would encourage you to use the chat facility, and we can join those together and have more control over the questions. I'll introduce the speakers in a minute, and we're going to take the two presentations sequentially. Before we start, I'd just like to welcome everyone, not only from all around Australia, but we've got people who registered from New Zealand and overseas, and obviously our keynote speakers from overseas as well. But for those of you in Australia, I'd like to acknowledge the lands that you're on at the moment and the traditional owners. And we extend our respects to elders past, present, and emerging. The purpose of this seminar is to bring you up to speed with where ANZELA is, but in particular to make it relevant to what's been happening in the UK. And you'll all be familiar with the National Emergency Laparotomy in the UK. ANZELA is very much modelled on that. And as a result of the work that NELA has been doing over the last few years, the Commission decided that it wanted to generate clinical care standards, which is what it does when it feels there is an area of care where patients aren't necessarily getting the care that they could and should expect. Those standards were launched at the college meeting on the 1st of May. And we will be going live with the updated red cap dashboard, which has been generated by Letty, and linking that to a dashboard which Letty and Fraser have adapted from the work that was done previously by the WA Department of Health. So that's where we're at. And now to introduce the first speaker, is Lyndsay Pearce, who is a consultant colorectal surgeon in northwest England. She joined the NELA project team in 2020 and became the chair in 2024. And you can see up there her presentation where she's going to talk about NELA and how it's worked in the UK. So Lyndsay, welcome. Thank you very much for joining us. We deeply appreciate it.
Thank you, James, and thank you for the invitation to present. I'm really excited to be part of this seminar, and it's good morning here in the UK. So I am partway through my ward round, but I've broken off to come and talk to you. So there's a sign on the door saying "Don't come in, I'm busy." So hopefully we'll get through the next 20-30 minutes or so without any interruptions. So as James said, I'm a colorectal surgeon. I'm based in the northwest of England. I work at a centre called Salford Royal, and I've been involved with NELA for many years. So I was a trainee in the UK, and NELA has become part of our training programme and very much embedded in our work and our practices. So I hope that over the next 20 to 30 minutes, it's just going to give us a little bit of time to maybe step off what feels a bit like a hamster wheel sometimes. We're just constantly driving forward, and it feels a bit like Groundhog Day. So hopefully give us a bit of time to reflect. Hopefully I'll be able to share some useful and motivational insights from the work that we've done in NELA. And ultimately, it's all about trying to improve patient care. But I think there are massive benefits to us as individual clinicians as well, and particularly to those that we train. So this QR code up here links to our nice, shiny and new NELA website, which was launched this year. We have 10 NELA reports that are published and all available on our website, but NELA has obviously collected data for more than 10 years now. Our report was published, the Year 10 report, in October of last year. So I just wanted to give you a little bit of background about NELA and where it's kind of come from, where it's governed, and how it all works. So NELA is what we call one of the NCPOP audits, which is the National Clinical Audit for Patient Outcomes Programme. And HQIP, the Healthcare Quality Improvement Partnership, is responsible for managing and commissioning that NCPOP programme on behalf of NHS England. And the NCPOP audits are included in trust quality accounts, and those quality accounts are essentially published reports about service quality and improvements which are offered by the NHS providers. They relate to patient safety, how effective treatments are, patient feedback about care, and really give sort of a national picture of care standards. And the NCPOP audit programme is really quite large. There are more than 30 audits included in the programme, of which NELA is one of the largest, and the audit feeds into that quality account. The data collected provides that national picture of care, and on a local level, the NCPOP audits provide trust with individual benchmark reports on their compliance and performance feedback, and I'll talk quite a lot more about feedback as we go through the presentation. So where did it all start? Well, for us, it started with the Emergency Laparotomy Network in 2011, and that work was presented at the AAGBI Congress in Edinburgh. It was undertaken by Dave Murray, who was the chair of NELA prior to me, and he was with the NELA programme for around 10 years. The project was unfunded. It was 37 sites, collected data on 1,800 patients, and it was the first prospective national audit around emergency laparotomy and really gave that foundation case for NELA. And at that time, the 30-day mortality was around 15%. And we've come a long way. So we now know that the NELA population, the population in the UK that undergo emergency laparotomy, is around 32,000 cases per year. We have in our NELA data set over the last 10 years or more, around 250,000 patients who have undergone emergency laparotomy, some who have undergone emergency laparotomy more than once in that 10-year period. We know that around 50% of our patients are aged over 70. We know about 50% are high risk, and we're now down to a 30-day mortality of around 8%. So that first patient report for NELA was published in 2015, and we're now heading into our 13th year of data collection, because there is a bit of a lag from when we report and when the data collection period ends. So the Year 10 report was published in October of last year, and the Year 11 report will be published in the autumn of this year. And we're able to deliver the audit because we have a massive team who are working together towards this shared goal of trying to improve emergency laparotomy care. And so I'm the chair, and then we have an anaesthetic lead, a surgical lead. We have a allied healthcare professional and nursing lead who's relatively new. We've had QI lead in the past. We have a really broad-reaching clinical reference group, and we report to our project board, and they're responsible for our governance. But on a local level, at our 176 sites, we have an enormous number of people who contribute data to the audit. And without their enthusiasm and dedication to the audit, we wouldn't be able to deliver the audit in the way that we do. And what's interesting about all of those sites is they're all quite heterogeneous in terms of where they are, the geographic population that they serve, how rural they may well be. And so they're all quite different in terms of how they have their infrastructure. And that's why we haven't really ever set out one size fits all best practice, because every centre is so totally different, and we really recognise that as a project team. And it is a team sport. So one individual in an organisation cannot deliver this audit. It really is a team sport. So we developed a job description for our local clinical leads, recognising that this work is really valuable, really important, and needs to be recognised as such. So we have our sort of job planning is done on programmed activities. And so we set out this job description recommending to organisations that if someone was to take on a lead role for NELA at a local level, that should be remunerated with half a PA, half a programmed activity. And we recommend that sites have clinical leads in anaesthesia, but also in emergency medicine, radiology and surgery. And there's really good reason for that. And when I took over the chair role, I think it was probably fair to say that we were doing quite well with the sort of operative part of our patient pathway. But the bits where we're kind of lacking really is what I refer to as the bookends of the pathway. So what's happening to that patient from the moment that they come into the organisation to when we get to that point where we've got a decision to operate? Because from decision to operate onwards, the pathway generally is pretty smooth and patients get to the theatre in a pretty timely manner. But what we've identified is that they have this really circuitous route throughout their diagnostic pathway from time of arrival in hospital. And we're not really harnessing that time frame and really intervening in the ways that we could do in a timely manner. And so through work with our RChem representative on our clinical reference group, we've really started to drive NELA in terms of the emergency medicine engagement. And the Royal College of Emergency Medicine actually put out a position statement around the recommendations for care for emergency laparotomy patients in the emergency department. And I think this is something that as a project we can really build on. We're really struggling in the UK at the moment in terms of ED waiting times, and there have been 2 or even 3 publications so far this year that have referred to the management of patients in what is referred to as the corridor care crisis. So patients being managed in areas where they wouldn't ordinarily be managed. And so when we look back and think about this paper that Hannah Boyd-Carson wrote around how a delay in source control for peptic ulcer patients translated into a significant increase of risk of death per hour, we sort of put that now into where we are working and the circumstances within which we're working and think, how is it possible to get these patients to theatre quickly in a timely manner? How do we give them antibiotics quickly when we're managing them in areas which is not really acceptable? And so when we look at the RCS guidance, which I know it features in your commissioning document as well, this 6-hour target for definitive management for those patients who require immediate surgery, how do we get them to theatre within 6 hours? It feels near on impossible. I'm not going to talk too much through the results of the 10th report because they are available on our website, and also what we do a lot of, and I'll talk a little bit more about this later as well, is that we have quite a good webinar program. So we have a YouTube channel which is hosted by NELA, and we arrange regular webinars, and we always do a launch webinar for the results of the report. So that is available, and if you're interested particularly in the Year 10 report, then do have a look and a read of that. I'll go into some detail of the results, but there's obviously more granularity in the report itself. What we're seeing is that there's still this variability. And in the interest of transparency, the yellow dot there is the organisation that I'm sat in at the moment, that's Salford Royal. But across all 176 sites, we do still see this variability. And what's interesting here is that the dots that we have here at the 99.8% of the 95% control limits, these are our alert level outliers, and then our alarm levels are anything above here. The mortality rates have fallen over the course of the NELA audit, but the variation persists. And the variation persists even when we look back at the emergency laparotomy network. There was that variability there, and it is possibly better now than it was then, but there is still variability, and that's what we really need to try and hone in on. We do open publication of our reports, and as I said, we host webinars and things for our report publications, but we also try and launch them at national meetings or Congress. We have really good working relationships with the Association of Surgeons of Great Britain and Ireland, and we often have a NELA session at those Congress meetings, during which we can really get some engagement with our clinical teams around the reports. We don't do individual surgeon level reporting. And if an organisation is identified as an outlier, we do notify them in advance so that they are able to review their data and ensure that the data that they have put into NELA is accurate. And so their outlier status is definitely accurate and confirmed before we then would publish that they are an outlying site. I'll talk a little bit more about it later, but starting in year 11, we're also going to be publishing the responses of those organisations. So when we liaise with an organisation for being an alert or an alarm level outlier, the response that they provide to us will be published on our NELA website. Our outliers are reported to the Care Quality Commission, and the Care Quality Commission is an independent health regulator of all health and adult social care services across England. They essentially inspect all of the NHS sites and they rate them between outstanding to inadequate. And there are regulatory and operation repercussions for their ratings. It has significant patient impact and obviously an impact on public trust. And impacts broader healthcare system dynamics as well. So CQC ratings are really quite important for care organisations in the UK, and an outlying site would be reported to the CQC. Having said that, it can be quite a positive experience. So as the chair of the audit, it's my responsibility to phone up the local leads at the outlying sites and say, we've got a problem, you've been identified as an outlier, do you want to have a chat about it? What do you think? And often, the leads already have got an idea that they may well have been identified as an outlier. They've often got some level of suggestion as to why they might be an outlying site, and they can use those insights in going to their medical directors and chief executives saying, look, you know, we've been asking for this, we've said that there's a problem with this process, we've not got enough resource here. And look, this is now what that's translating into, that we are an outlying site for mortality. So it's not all bad. And actually, most of the sites that we liaise with actually welcome the notification of the outlier status because it gives them a platform in which to be able to really address it with their senior leadership teams. So we follow the outlier management process from the Healthcare Quality Improvement Partnership, and we alert organisations based on their risk-adjusted mortality performance. And we also, which is new for year 11, is that part of our outlier policy will also include case ascertainment. So that is the number of cases that people are putting into the NELA data set compared to the number of cases that are being undertaken at that site. And that has been really interesting, and I'll talk a little bit more about that later because that has really had significant QI implications. So what all of that is trying to do is to try and avoid that variability and try and make sure that people stay within the kind of acceptable levels of mortality for these patients. So this is just the quote that we have on our website. So the identification and management of outliers in accordance with published NCPOP outlier guidance. And we will be publishing the responses from our organisations that have been identified as outliers. Some of those responses are actually fantastic. The level of investigation and engagement that sites have been able to demonstrate has been actually fantastic. There are some exemplar responses. So I'm sure everyone will be very interested to see what the responses are of the outlying sites, but some of them really do map out how to really investigate issues within your department and come up with some strategies about how you might want to address them. So that's a big QI element, I think, for that part of the process. We are really, I mean, obviously we're a quality improvement audit, that's what we're trying to achieve, but we're really pushing our quality improvement plan. So we have our webinars, we also have what we call our shiny dashboards. So this is real-time data at hospital, regional or national level. It's openly and publicly available. You can use the QR code and have a mooch around the shiny dashboards. And what this enables sites to do is it really allows sites to understand the change that's affected. So if they make a change within the organisation or a process, what does that look like in terms of their real-time data? When we've contacted outlying sites, the two themes that come up quite regularly are the importance of ASA grading. So making sure that your data is accurate is essential. So your ASA grading, because that affects your risk adjustment and decision making. And I'll come a bit more onto decision making afterwards, but that is a huge thing for our emergency laparotomy patients, and particularly around communication with patients and communication by different members of the team. And I'll talk a bit more about that. We held a webinar in 2022 for some of our top performing sites. So you'll note that I've talked about outliers in a negative way, but we also have some positive outliers. We don't have a positive outlier process, though that's something that is being discussed at sort of HCLIP level. But we do have some really good top performing sites. So in 2022, we had a webinar, which again is available on our website, where we had speakers from Addenbrooke's, Bath, Norfolk and Norwich and Huddersfield, who all talked through some quite different elements of their care pathways which benefited patient care. Our current surgical lead, Edwin Clark, is a clinician at Stepping Hill Hospital, and they have persistently and consistently been a positive outlier. So the themes that came up through that webinar, I'll just briefly talk through. So Addenbrooke's felt like their rota was really a positive, had a massively positive impact on them being a positive outlier. So the way that they were able to deliver consultant level care, having upper and lower GI daytime clinicians, having ready access to other multi-specialties, and being able to provide really good levels of consultant-led care. Norfolk and Norwich had developed a novel electronic theatre booking system. I think it was one of their anaesthetists that developed it and then continued to add to the software. That generated an automatic NELA risk scoring, which then was transparent and available to critical care and anaesthetic services. It then put patients into sort of a red, amber, green in terms of their assessment, and it gave them a really robust platform to then be able to pull the cases out, to then be able to add them into the NELA dataset. They also had an emergency surgeon who'd done a diploma in geriatric medicine from the Royal College of Physicians, and so they were achieving some of their geriatric medicine and perioperative care for older patient metrics through that training that individual had had. The Royal United Hospital Bath had what was called a code laparotomy, and that was essentially related to radiology booking. And if you put the words code laparotomy in, it just ended up with this radiology pathway where patients had scans that were reported within an hour. They also had what they referred to as a boarding card bundle, which was a package of care and provision that patients who were going to have an emergency laparotomy had. There was an urgency RAG rating on their theatre booking system, which wasn't automated and needed some manpower to put in, but that allowed them to really be able to prioritise cases and move patients around. One thing that they also did that we don't do in my organisation is that they put in anticipated surgical time for their emergency patients. They also had an emergency laparotomy trolley for anaesthetists in theatre, so that all the kit was readily available and could be implemented rapidly. They talked a lot about the importance of feedback to colleagues. And again, this comes back to different organisations and different infrastructures. And so lots of different organisations work in different ways. Some like meetings, some like posters, some like emails, some like newsletters, some like, live presentations. So just making sure that there is a robust feedback process. Huddersfield talked quite a bit about governance and would discuss in governance any emergency laparotomy patients who stayed more than 5 days in hospital. They cited having a laparoscopic approach was not only beneficial to patients, but also suggested that there was a level of consultant level care. And also highlighted that it's not just the emergency laparotomy care that if you improve care for the emergency laparotomy patients, but actually looking at other areas of your acute surgical practice, whether you've got a really good ambulatory unit, because that could potentially free up time, space, capacity and resource for emergency laparotomy patients. But what they did say was don't declare victory too early. And certainly it is quite easy to go from an outstanding trust in the CQC rating to being requires improvement. And I think this just goes to emphasize that it's not an individual that can generate these changes. It's teamwork, it's a team sport, and often it's a cultural change. And we had a shift within our NELA project team. So I was quite keen when I took over that we actually looked towards broadening our project team in terms of who was representing on there. And I was really keen to get a NELA nurse and AHP lead onto our project team. And the reason for that is that nursing is the largest safety critical profession in health and social care. We have 750,000 nurses in the UK. They are always present and they are there at every single point of that patient's pathway. And patients often feel really comfortable talking to them as well. So we appointed Angeline Price as our NELA nurse and AHP lead, and she's been absolutely fantastic in generating a nurse network and also being able to talk to patients. So we've now got a really good grasp of the emergency laparotomy specialist nursing roles and what they do. And again, there's a webinar available on our website if you want to know more about that. They allow for early identification of patients. They allow patients to be pulled through the process. They're also involved in follow-up and often data collection. So the vision really is that we try and expand those nursing networks across the UK. And with the right support and the right environment and the right encouragement, these individuals can really affect massive change. So this is Guy Aries, who is one of the specialist nurse practitioners at Northumbria Healthcare. He is now our Royal College of Nursing representative on our clinical reference group. And he's been really instrumental in improving the care of NELA patients at Northumbria, in a sort of trying to pull them through the pathway, almost in a kind of stroke or trauma type model, where you're proactively seeking to identify patients in A&E who have been through triage, who may be parked on that corridor, who haven't really been picked up to the surgeons yet. So in terms of data, I've touched on it briefly. We don't sort of recommend a best practice, but in terms of data collection, we kind of recognise that probably prospective data collection is probably better. Wherever possible, and that was one of the things that Bath mentioned about having an iPad in theatre and really trying to engage the theatre team in putting the information in real time. We're really conscious to try and reduce the data burden, but the way that we need to reduce data burden is probably to rely on other data sources to pull into our NELA data set. And we can only do that if we've got really robust accuracy of data being put into those systems like coding and HES. Now, I touched on it briefly before, but with case ascertainment in year 11, we have pulled up some issues around coding, particularly where we have sites who are not emergency sites, so maybe provide simply just routine cancer care and don't have an emergency service provision. They tell us they don't do any NELA cases, whereas they're not including their returns to theatre, and so that's a problem. But also where patients are moving from an A&E with a centre which doesn't provide emergency laparotomy care, and then patients are being transferred elsewhere. And so there are lots of issues around coding, which I think it's really important that we continue to feed back, because that is quality improvement in itself. We review our NELA data set annually in order to make sure that we are relevant. So what are the successes of NELA for the purposes of this seminar, and what do I think our real success stories are? Well, post-op length of stay has fallen back to 10 days and mortality is reduced to 8.1%. We know that. But really our risk assessment, defining risk status, and our risk score has been probably one of the most successful elements to come out of NELA. So 81.3% of all of our patients are risk assessed, but the risk score was developed because really we recognise that other scoring systems were not so good. We did this piece of work back in 2018 where we generated a NELA risk score, but there were pre and post-op variables, and it was quite onerous because there were lots of different variables that need to be inputted. So in 2023, we published the work that we did around the parsimonious risk score. That was work that was done on 62,000 patients. So it was developed with 41,000 patients and then validated in 21,000 patients, which is why it's a very good scoring system for emergency laparotomy patients. But obviously, it's only validated within our NELA population. We reduced the number of variables, and they're all pre-op variables. But that's had massive international impact. So there are papers upon papers that are being published all the time looking at the NELA risk score and how it's performing within different countries and different populations across the world. So for me, the NELA risk score has been probably the most single impactful thing that NELA has done in the last 10 years. I'd strongly encourage you to use the risk calculator. I would say that, obviously, but it is available on our website and on the landing page. And you just click on the right-hand button, and you'll be able to calculate a risk score for your patient. Having said that, the assessment of risk is actually pretty simple and pretty straightforward, and it's not changed very much. This was year 6 data, and we can see that if you're over 50 and you have an ASA grade that is 3 or greater, you're essentially high risk. So there are simple ways of assessing risk that doesn't include going onto the website, but the website's the most robust one. In terms of our critical care provision, most of our patients are admitted to critical care who are high risk, and I know our definition of high risk is slightly different to yours in terms of the percentage risk. Ours is 5%. We still have a number of high-risk patients who are going to ward level care, and that's something that we need to address. But there are also low-risk patients who are also going to critical care as well, which is fine if you've got that provision of critical care, but we don't want to deprive other people of that care. What that has enabled us to do is to try and work out how many critical care beds you might need per 100,000 adults per year, and so it helps in terms of provision of resource. But there's still variability. Frailty assessment has been a big sort of impact thing for us. We've started to include frailty assessment and recognise the importance of that, and not only the importance of frailty assessment, but actually that a lack of frailty assessment does not mean that there's a lack of risk, and those patients actually have in hospital mortality scores that are much more in keeping with frail patients. Specialist care for older patients we could talk about for a very long time. We know that this is impactful. We know that it benefits patients. The difficult thing is how to deliver it consistently across care organisations. But what it has done is it has really enabled us to engage with our geriatric colleagues and open up conversations around shared decision making. Our post-operative length of stay has also dropped off. But when is high risk too high risk? We've had some fantastic fellows within NELA, and one of those was Hannah Javamard-Amagissi, and she published a number of papers, particularly around high risk, early post-operative death, and around futility. And so this is what I mean when I talk about centres that are outliers. Often the centres that are outlying are those who are perhaps having patients that are dying early post-operatively, and then the question is, should that patient have had an operation or not? She looked at the on-table deaths, and we know that most of our on-table deaths occur in the highest risk patients, but a lot of those are living in their own home. We know that intestinal ischemia is a significant risk factor for that. You will all be aware of the ELF study, which started our sort of journey into NOLAP, and some of the other studies that were published internationally around that. But ELF was the first prospective audit. And whenever I'm discussing cases with trainees in the middle of the night, these are the two charts that I send to them. And the reason why this is important is that we need to really remember how impactful frailty is in terms of mortality and also in terms of increased level of care on discharge. And we know from other work that colleagues have done that patients are actually not that interested in mortality. In this Delphi study that Jen Law did, they want to know about independence, post-op complications, readmissions, requirements for stomas, and delirium. Mortality does not really feature in what patients want to know. Communication is absolutely key here. And I think that if there is something that we can do in terms of training and education, it would be really helpful to try and encourage organisations and colleges to try and develop some advanced communication training packages for our trainees and fellows around having these really difficult conversations out of hours. And so ELF2 was the prospective study that looked at our NOLAP patients. And then we have now published our first NOLAP report that was launched at the Anaesthesia Conference in May of this year. And our NOLAP work has really been undertaken by Eneng Lo. She's one of our fellows who, again, has worked tirelessly and been very dedicated to the NOLAP work stream. It's been really hard to set up this NOLAP work stream. It's taken a lot of time and engagement from national and international colleagues around what's important and what we should be auditing. We're kind of stuck on this case ascertainment bit. It's really hard to know how to develop a case ascertainment policy for these patients, and I don't know whether we can. We hope that the NOLAP stream would continue, but I'm not sure about the sustainability of it in the funding envelope that we've got, and I think that our centres are finding it really hard work to collect that data. So we included in our first year of NOLAP patients with bowel perforation or suspected ischemia, and we had 5 standards around risk assessment, care of the older, surgical patients, CT scanning, advanced care planning, and end-of-life care. And we tried to mirror those against what we'd got within our emergency laparotomy work stream. So we collected 943 patients from 91 hospitals, and more than half of those were female, and most of them had bowel perforation, and less had ischemia, but not a significant number. So risk assessment, 72.3% had a formal risk assessment, and all our recommendations within our reports are upward facing, and so we made some upward facing recommendations around risk assessment. Care of the older surgical patient, so 85.8% of patients had a formal assessment of frailty, which is good, and I think within the UK certainly everybody is recognising the importance of frailty assessment. Most of our patients have a CT scan. One of our standards is around communication, and again we see a similar thing in the emergency laparotomy patients, that communication of those is poor. Advanced care planning I really wanted to mention, and I know that's something that features quite heavily in practice in Australia and New Zealand, but we don't have a goals of care thing, in which I'm trying to drag the surgical community into understanding a bit more about advanced care planning and about what it means for our patients. So we have lots of different types of advanced care planning within the UK, and clinicians can become quite confused, I think, with all these different aspects of advanced care planning. But we have a lot of opportunity within our elective practice to be able to start to have these conversations with patients, and also start to try and make some of those documentations. So most of our patients, well, a significant number of our patients don't have any advanced care planning in place. So again, we've made some upward facing key recommendations. And then the last bit around end-of-life care. So 80% of patients who died in hospital had a documented end-of-life care plan, but only 62% received input from palliative care team. And I think that just kind of reflects, the importance of dying well, and we need to be having these conversations with our patients and in a multidisciplinary way. So in-hospital mortality for our NOLAP group was 76%. So there are a number of our patients who are still alive at 30 and 90 days. So where do we go from here? And I'm aware that I am over time, and I will try and rattle through these last few slides quickly. So where do we go from here? Well, first of all, I know that the 2018 Royal College of Surgeons of England guidance features quite heavily within the commissioning document for Australia and New Zealand, but we think that this is quite out of date now. 2018 was quite a long time ago, and in year 9 we actually made a recommendation to say that the Royal Colleges should work together to publish consensus pathways, and we haven't seen those yet. So we're continuing to put some pressure on our college colleagues in order to be able to try and drive this forward, to try and reflect standards which are going to improve patient care within the infrastructures that we're currently working in. We still have issues around infection management and the administration of antibiotics and source control. And that's one of the reasons I wanted the nurse lead role, because I felt that our workforce is now so broad. We have people who can prescribe antibiotics who are not doctors, and so we need to be also getting the message across to them. So our infection management standards come from the Academy of Medical Royal Colleges, but we see that patients are still waiting much longer than they should be to be given their antibiotics. And it's bad pretty much everywhere. There's still variability, but generally it's bad. And time of arrival to theatre. So this is what I was trying to get at with that circuitous pathway that we see within the emergency department, that even our sickest patients with suspected septic shock are taking 12 hours to arrive in theatre, and that's simply not acceptable. I'll skip over that one. So again, it's bad, there's variability. So there's lots to be done, but there is lots more that could be done. So the areas that I think I would like to try and consider for NELA over the next few years is relevant standards updates, maybe looking at things around nutrition and pain management, particularly patients who've got a history of chronic pain. Whether we need to expand the audit to include complications of appendicitis or biliary surgery. Primary care, I know primary care features in your post-operative sort of discharge planning metric, and we don't have any primary care stuff within our NELA data set, so maybe looking at primary care. Maybe trying to remove some data fields. So we've got thousands and thousands of patients, and if we're looking at a metric that we've not actually analysed or done a subgroup analysis on, maybe we just need to box that off, do a subgroup analysis and move on now that we've identified what the data says. Again, continue to try and look at reducing data burden, look at bulk uploads into our systems and the accuracy of our HES data. We need to think about the sustainability of NELA. We need to continue to have fellows because I think they're enormously helpful, not only to our work streams, but also just in our project team and the dynamics and the way that we work as a team. There's lots to be done around PPI. We've got a PPI webinar coming up later in the summer. There's some work to be done around health inequalities. We've uncovered some uncomfortable inequalities around gender and waiting times to get to theatre. We need to think about funding if we're going to do any additional subgroup analyses and how that would work. I'm really keen to look at international collaborations. I think that emergency laparotomy care is something that's being looked at internationally now, and it'd be great to try and set up an international group, and the role of artificial intelligence as well. So I hope that whistle stop but lengthy chat has given you an opportunity to think about how you can maybe take a pause on the hamster wheel and maybe just stop and think about what you're doing and how you're doing things and whether things could be done better. I know that I find being involved in NELA really fulfilling. I think that it's probably one of the best bits of my working week, thinking about all of these things. So I think we need to embrace heterogeneity. We should seek challenge and try and affect change. We need to build better working relationships and teams and share our learning whenever we can. So thank you to all of you for listening, but also to all my colleagues at NELA, to all of the local clinical leads, all of the participating sites and all the audit departments, and also to our fellows. If you're interested in signing up for any of our webinars, you can get to them through the events and education news section of our website, and we have our NOLAP launch webinar that is coming up on the 24th of June at 1 p.m. UK time.
Right, Lyndsay, thank you very much. You certainly give us enormous amount of information there for us to think about, some of which will doubtless come up in the questions and comments. I'd like to move on to the second speaker now, And I particularly want to thank Phoebe Holson-Kimmer for talking tonight, because she's had to step in at short notice for our original speaker. She is an entirely appropriate person to do this, because she was the co-chair of the Emergency Laparotomy Clinical Care Standards Working Group. So she sat through, indeed chaired, all the meetings that the Commission put together to produce the clinical care standard, which she'll talk to you about in a moment. When she's not doing that, she works as a GP and as a senior lecturer in general practice at Sydney University. So Phoebe, welcome, and thank you very much for agreeing to address us tonight. You're on mute. Someone will have to unmute her.
There we go. Are you able to hear me okay? Can you hear me okay? Yeah, beautiful. Thank you. All right. Thanks so much, James, and thank you, Lyndsay, for that fantastic presentation. And I'd really like to acknowledge the role that NELA's played in supporting ANZELA's approach to emergency laparotomy over the last decade or so. I'd also like to thank James, ANZELA and RACS for their collaboration with us here at the Commission during the development of the clinical care standard. So today I'm going to be talking about the emergency laparotomy clinical care standard, which has been in development at the Australian Commission on Safety and Quality in Healthcare over the last 2 years or so, and as James has said, was just released last month. So as a bit of background, the Commission leads and coordinates improvements in the safety and quality of healthcare across the system in Australia in partnership with patients, clinicians and organisations. For those of you who are not necessarily familiar with clinical care standards themselves, just a bit of background. The Commission develops clinical care standards to support appropriate high quality care for particular health conditions or procedures, and with the purpose of driving evidence-based quality improvement in areas of unwarranted variation in care or in outcomes. And you can see some of those titles on the right-hand side there. And emergency laparotomy is the Commission's 20th CCS, and they undergo regular revision as well. So with these clinical care standards, they comprise of up to 10 quality statements, which are fairly short, which describe the clinical care that a patient should be offered to really address what, those quality improvement priorities or crucial aspects of what is considered effective care. They also need to be underpinned by strong evidence base, and under each of those quality statements is further more detailed information for consumers, for clinicians and for healthcare services. And the quality statements are accompanied by a set of indicators to support local monitoring and quality improvement. I guess it's really important to say that clinical care standards are quite different from clinical practice guidelines. Guidelines tend to be quite a bit more granular and giving clinicians advice about what to do in particular clinical situations, where a clinical care standard is much more at I guess a more conceptual level, making sure that those really important pieces of the puzzle in the patient journey are being provided, but also coordinated consistently across different health services. The Commission's also developed the Australian Framework for National Clinical Quality Registries. And in Australia, we've got an excellent foundation of quality improvement where there's alignment between evidence-based clinical care standards and a number of clinical quality registries. So examples that you might be familiar with would include stroke and hip fracture, and now emergency laparotomy. So those, I think, work very well hand in hand, the CCSs and the clinical quality registries when they're planned in that way. Just to take a bit of a deeper dive on hip fracture, because I think it's just such an excellent example of this. Since the Australian and New Zealand Hip Fracture Registry commenced in 2015, and then we had the original hip fracture clinical care standard introduced just 1 year later in 2016, there's been substantial improvements in the care provided to hip fracture patients across Australia. Over this time, participation in the registry has grown significantly, and the CCS and the registry have worked hand in hand to support an evolving standard of care. And if you have a look at their website, the ANZ HFR website, you'll see some examples of the activities that they do to involve clinicians and consumers in what I think are really engaging and multidisciplinary ways. So in this recent study from New South Wales published in the MJA, researchers were able to demonstrate that a high level of adherence to the clinical care standard that was described in the clinical care that's described in the clinical care standard led to a 60% reduction in 30-day mortality risk for hip fracture patients. So good to see that evidence base there also. I guess the implementation of relevant clinical care standards and participation in CQRs are really important ways that services can demonstrate strong clinical governance under the National Safety and Quality Health Services Standards, and good practice really in relation to quality improvement and the delivery of evidence-based care. At the Commission, we are often asked about whether clinical care standards are mandatory, and most clinical care standards are not, and similarly, participation in most clinical quality registries are not mandatory. However, we see them as really important opportunities to demonstrate care that align with those general principles in the National Safety and Quality Health Standards. Another thing that we'll talk about a little bit more later on is around the context where the clinical care standards are going to be implemented, and that's an important consideration for thinking about how to implement CCSs. As I think James has spoken about a little bit already, you know, this has been a long time coming, and there's been a lot of groundwork that's been laid down over the last, over a decade. Just to provide a bit of context for what's come before this, the development of the emergency laparotomy CCS, a group of motivated clinicians first came together in 2017, and then after that, RACS and ANZELA agreed to establish a working group that led to the establishment of ANZELA-QI. The Commission's interest in this work, though, really came about since the Victorian Perioperative Consultative Committee approached us in 2021, advocating for a CCS, and we've been working on this since 2024, with the standard being launched just last month, and then further ANZELA-QI indicator alignment being launched or happening from the 1st of July, so just next month. So the standard was developed with guidance from a topic working group. Some of the members are here today at the seminar, and with broad input from a range of stakeholders. The standard was launched, as I said, very recently, and really the goals are to optimise outcomes for patients, ensure high quality and timely assessment, diagnosis and management of the patient requiring an emergency laparotomy, and to support good practice in decision making. So partnering with patients or consumers and understanding what their preferences, values and goals of care are. So I'm just going to quickly talk through the quality statements that describe what we feel are the priority areas for quality improvement when it comes to emergency laparotomy. And you'll see that there's a lot of similarities here between with what was presented just earlier. And again, for those of you who are familiar with the CQR, you'll also identify the alignment with the ANZELA-QI indicators here. So I think it's useful to present these quality statements under a few key themes. And the first one is around time critical management. So quality statement 1, which is referring to rapid assessment, escalation and surgical referral, and being aware that there's a heightened risk for patients presenting with or developing sepsis. Our quality statement 2 is around the importance of timely CT in supporting diagnosis and planning for surgery, acknowledging that there are some rare exceptions when surgery is too urgent to delay for those investigations. And then quality statement 5, which addresses the critical importance of timely access to surgery. The next grouping of quality statements really do relate to the risk-based pathways. So quality statement 3 is that risk assessment which Lyndsay's spoken about, which is a risk assessment before surgery using a validated mortality risk prediction tool in addition to clinical judgment, and that should be accompanied by assessment of frailty, cognitive impairment, and delirium risk. Then that flows on to quality statement 6, which is around for high-risk patients, a consultant surgeon and a consultant anaesthetist should be present in theatre during the surgery. And then quality statement 7, which is where there should be a discussion preoperatively wherever possible with a consultant intensivist about the patient's postoperative clinical care needs for that high-risk patient. Embedded throughout all of this is the importance of shared decision making and goals of care, including particularly when patients and families are considering surgery that may be non-beneficial, and the involvement of senior doctors in those discussions. This is a slight departure, I guess, from existing ANZELA indicators, but we feel extremely important for this older cohort. And I believe from the 1st of July, the CCS indicator relating to documented goals of care will be included in the ANZELA data collection to support measurement of this quality statement. And then finally, but very importantly, it's quality statement 8, which refers to the importance of older patients receiving appropriate, timely and collaborative medical management from a suitably experienced geriatrician or other appropriate physician. And this may include a rural generalist or a rural GP in some settings. And then finally, that preparation of for transition from hospital care, which includes a detailed individualised care plan. As I said, the standard includes a set of indicators to support local implementation and quality improvement. And I guess as we think about implementation, it's really important to acknowledge that patients who require emergency laparotomy are presenting in all sorts of settings in Australia, including regional, rural and remote settings. And then emergency laparotomies themselves are also being conducted in all sorts of different contexts. And so I guess in addition to the quality statements themselves, the standard addresses key areas of risk, including transfers, which may be required for further investigation, the surgery itself, or post-operative intensive care. The standard also acknowledges that in some settings, quality statements will need to be interpreted flexibly to suit local circumstances and the needs of the local population. So those sorts of flexible arrangements may involve, for example, strengthening links with referral hospitals or considering alternative ways of comprehensive geriatric assessment for older patients. There's so much excellent work underway in this area in Australia, and for some services, the care that's described in the clinical care standard is already routine practice. Here on the left side is a picture from the launch event at the ASC just last month, showing Dr. Jacinta Cover, who's a general surgeon at Bunbury Hospital in WA, talking about how their hospital's participation in ANZELA-QI has driven really significant improvements to their care. I guess for other services looking at the clinical care standard, they may identify gaps or challenges, but we do really believe that the release of the standards is an opportunity for all services and clinicians to review their clinical practice, their current workflows, identify key gaps and drive improvements in the way that care is delivered. So together with participation in the registry, we believe that this is a significant opportunity to bring about improved process and outcomes for what are often the most unwell patients in our hospitals. If you're interested in having a look further at the standard, the indicators and those further details, that QR code will take you to our website and the standard. And thank you for having me here to talk about the clinical care standard.
We're up to time, but I'm going to just run over a little bit because we won't often get an opportunity to talk to Lyndsay. And if anyone has got any questions, please put your hand up. We'll unmute you. Lyndsay, just to start the ball rolling, just a couple of issues. Undoubtedly, one of the issues that is of concern locally is the matter of data burden entry and when it's done. We try to encourage people to do it in the theatre, not as successfully as I would like. I wonder if you have any comment about that. And the other issue I'd be interested in is about how you're going to tackle case ascertainment and ensuring that you've got all the cases that you really should have.
So first of all, in terms of when to collect data, I think it's very difficult to be really prescriptive about it. And I think you have to work within your local organisation to work out what works well for you, and what is the easiest way to collect the most accurate data, because that's ultimately what you want. And for some organisations, that may be clinical audit departments. So for example, in my organisation, actually the clinical audit department has taken the lead on collecting this data, and the clinicians don't actually have that much involvement in collecting the data prospectively to put into the NELA data collection tool. They are directly contacted and then fed that information is then fed back to the audit department, and that ensures that the data is really accurate and it's really complete. But in other organisations, it's giving everybody a individual login themselves, and that is probably the more popular and more common approach, so that the data is entered in real time. Putting it into like the WHO checklist in theatre has been quite a good thing. You know, is this a NELA case when you're booking it, so that the anaesthetists know that they need to open it and start, making sure that you discuss it at team brief and make sure that you discuss it at the sign out. Has the NELA or the ANZELA documentation been completed? Who's going to do it? Who's responsible for it? And making sure that the patients are registered. That's the first one. In terms of case ascertainment, I think case ascertainment for our emergency laparotomies is really good. I think we've got a really good handle on that. I think what some organisations don't have a good grasp of is that even though you haven't got an emergency department and you're not operating on perforated diverticular disease or a perforated duodenal ulcer, your returns to theatre are still part of the data set. And so it's getting organisations to recognise where they have got patients that are included. The issue that we've uncovered with coding has been fascinating, and I think has much higher level impacts than just emergency laparotomy care. For the no-lap patients, I think it's impossible actually to get truly accurate case ascertainment data for the no-lap patients. We've tried multiple different ways, we've tried multiple things through HES, and we've really not made significant progress. I think the patients land in different areas of the hospital. They are seen by different specialties, and they're not all seen by a surgeon. Some of these decisions are taken by the medical teams, and unless we're able to really disseminate information wider and encourage greater participation, I think it's really difficult. But we have found that the emergency laparotomy nurses or acute care practitioners working with emergency laparotomy patients or in acute surgical care have been absolutely key. The centres that get the most accurate data and the most complete data often have nurses working.
I think it's a very important issue in these high-risk cases, because obviously the post-operative mortality is the reciprocal of the no-lap cases, and it's very difficult to interpret a hospital's mortality if you don't know what their no-lap rate is. And we did some early work, and again we struggled like you, but we were able to demonstrate that there probably is a relationship between post-operative mortality and no-laps. But I think you've given us so much information to think about. What I would say is that a lot of the issues you've raised are issues that we know about and we're trying to confront, like the importance of getting a risk assessment pre-operatively, which we've been pushing hard. I don't see any hands up. If anyone's got any questions, You'll need to put your hands
James,
up
there's a
properly.
question in our chat. I'll just read it out for you. Will
Yep.
Department of Health fund data collection? For example, data collectors, surgical registrars, areas are already very stretched already, and or kind of an ANZELA-QI subscription, and that's from Peter Bird.
You want to take that, Phoebe, or dodge it?
I'll hand it to you first, James.
Look, I think we're a bit like what Lyndsay said. We can't be prescriptive to hospitals as to how they collect the data. It's a local decision as to whether they want it. What we can show is that in the data that we've got, as hospitals have collected better quality data, their performance has improved, and it's difficult to know how much is due to better data and how much is due to improvement. When the dashboard comes out on the 1st of July, for each metric, we'll be reporting alongside it the completion rate. So you'll be able to see if you get to patients, only 50% of your patients get to theatre in time, you'll be able to see that's only based on 50% of your data, and that'll be right there in front of you. And obviously, if you're missing half your data, then your care standard is not going to be easy to interpret. Lyndsay, I could talk to you all night about some of the issues that you've raised because they're so germane to what we've got to do. If we haven't got any more questions online and speakers, I think we're 5 minutes over.
We have one more
Yep.
question, James. So the other question is, has the mortality rate improved because of the better care or better case selection / avoiding futile operations? And that's from Warren Hargreaves.
Do you want to take that, Lyndsay?
Yes, so I think it's both. So I think we saw initially in the first years, I think we saw improved care because improved mortality because there was improved care. I've no doubt about that. I think we then saw that mortality sort of plateaued a little bit. And I have no doubt that the concept of NELA, the acceptability of not operating on somebody and that being an acceptable care pathway for them in the right circumstances, I've no doubt that that has impacted the mortality figures for our emergency laparotomy patients. And we have seen year on year that the number of on-table deaths has come down. And that therefore suggests that we're getting that decision right. I don't think anyone should die in theatre on the table. I don't think that is acceptable to patients. But what I think we're now faced with is if we're going to drive this mortality figure down further, we need to look again at improved care. And that improved care is going to come from the front door. In that first part of the diagnostic pathway, and it may even come before that. So it may come from primary care, it may come from addressing nutrition better. There's going to be further aggregation of gains. Maybe some of those will be marginal, but across the pathway, I think we can still improve care. We just need to look in different places.
Do you encourage the assessment of sepsis in your emergency department with Muse2 or another score?
So again, it's different across all different hospitals. They tend to use different scoring systems. So we use Muse2 as our scoring system within the organisation that I work in, and that is what is it within our data set because that's what most people use. But there are other measures which people are using. I think the important thing about the new score is that it's not the be all and end all. So you still have patients who are profoundly unwell with acute surgical pathology, which needs operative intervention, who may not have had that disturbance to their new score. And so I think it's more around education, training, awareness, trying to pick up people who've had previous surgery, who are in pain. I think often patients who've had previous laparotomies who present with abdominal pain, often they might not have a change in the new score, but there's something catastrophic's gone on and they get left for hours and hours without any intervention. So whilst I think news is important, definitely is hugely important for sepsis. It's not just about sepsis.
Okay, listen, we're now 10 minutes over our allotted time. So I'm going to wind this up. All the best parties come to an end while everyone's enjoying themselves. I'd like to thank both speakers really sincerely for their presentation. We've got a good foundation here now in Australia, and we've now got to build on it. And Lyndsay, I've absolutely no doubt we'll be coming back to you, picking your brains again in the future. And thank you very much for everyone coming on. This webinar was recorded. We will put it on the website as soon as we can. We would encourage you to ask your colleagues and both surgical and others to review it and to look at it. And doubtless we'll follow Lyndsay's view, and we'll do other webinars into the future. But for the meantime, thank you very much and good night.
Thank you.